And we're back. We have Bradley Neal, or Brad. Brad, you came on episode 56, so 2 or 3 years ago at this point. If people haven't listened to that first episode or just aren't familiar with you, can you give a little intro on yourself and what you do?
Yeah, pleasure. So I'm a physiotherapist by background, qualified back in 2006. So I've been a physio for a fair while. Currently a lecturer at the University of Essex here in the UK, where I've got a research role, but I do a little bit of teaching on a variety of programs and supervise master students, PhD students, etc. Clinically, have always been pretty musculoskeletal focused. Have done a variety of things. Did some time in elite sport. Did some time in our National Health Service over here. The bulk of my clinical work was in private practice, where initially see a little bit of everything, but then predominantly lower limb, and then patellofemoral pain is my sort of big academic focus. And yeah, when I came on, I think it was in the middle of the pandemic when I came on last time. We were talking about some of the works that make up this guide that we're going to be talking about today. So a nice example of how long research takes sometimes.
Yeah, so this will be kind of a part two or an updated conversation from a few years back. And I re-listened to it a few months ago, actually, no, a few weeks ago. And I think at the end, you were talking about this best practice guide. So now that it just comes out in 2024, it just goes to show how long some of this can take. Let's initially start with the best practice guide itself. So you were the primary author of this new best practice guide that came out this month or last. Title was Best Practice Guide for Patellofemoral Pain based on synthesis of a systematic review, the patient voice, and expert clinical reasoning. And we were potentially going to have one of your co-authors, Simon Lack, on as well, but he's in a conference. But can you just tell the audience what this best practice guide is and what your contribution is or was, and then we can dive into the topic itself.
Yeah, sure. So it's in essence, it's a mixed methods project. So clues in the title, and it's a very long and quite chewy title. Normally, we try and have titles that are slightly more catchy on the eye, but it is a combination of three different empirical manuscripts in essence. So we've got the big systematic review that underpins the evidence synthesis, which was published in JOSPT 2002, I think, 2022. And then we've got a couple of different qualitative manuscripts where we've got some semi-structured interviews from people with patellofemoral pain and also expert clinicians that research and treat patellofemoral pain. And in essence, we've put all of that information into a mixing bowl and tried to bring it together to come up with a guide for treating people with patellofemoral pain. And there's some objectivity around those methods, which I'm happy to go through. And yeah, it's a huge team effort, right? So I happen to be the lead author on the systematic review and this particular manuscript, the best practice guide. We had some very capable postgrad master students who were the lead authors on the qualitative manuscripts, both of whom have since graduated and gone on to do other things. Christian Barton from Australia, friend and collaborator, did a lot on the systematic review. And then, as you mentioned, Simon and Dylan from QM, but also I'll point towards Claire Bartholomew, who's Claire's actually a medical doctor, and she's currently a surgical trainee. She did the master's program with us at QM and proved to be a proficient researcher and has just always stayed involved. So Claire did lots of the nuts and bolts of the qualitative work, checking some of the qualitative transcripts and sort of second analysis on those things, as well as the systematic review and the guide. So a huge team effort and underpinned by some very useful funding as well. Research doesn't happen without funding. We had a small project grant from the Private Physiotherapy Education Foundation, who are a private charity-based funder here in the UK. And they've recently given us £500,000 to make 6 more of these things. So it's now a well-established method that we're going to go on and repeat for some other common MSK conditions as well.
Do you already know what MSK conditions you all will be working on?
I can tell you a couple. So we've aimed to underpin the decision with as much patient and public involvement as we can. So the first two conditions are lateral elbow tendinopathy and rotator cuff related shoulder pain. And then the other four conditions are to be decided based on some follow-up PPI work.
Got it. Well, I look forward to those when they come out. Let's just start with the diagnosis itself and the definition. What actually is patellofemoral pain, Brad?
It's a diagnosis of exclusion for people that present with pain at the front of their knee, in essence. So if we sort of see anterior knee pain as the big umbrella, patellofemoral pain is one of the specific diagnoses that can sit within that umbrella. But as a diagnosis of exclusion, we're looking to rule out other concomitant pathology that can present in a similar way. And then if we get rid of everything else, patellofemoral pain is what's left. So it's far from perfect in terms of concomitant pathologies we're looking to rule out. So, for example, patellar tendinopathy would be one. I don't personally think that's that difficult. Patellar tendinopathy is typically localized, sort of single finger location of pain, as opposed to patellofemoral pain, which is a very sort of broad, messy, heterogeneous presentation, can share some sort of aggravating and easing profiles. Patellar tendinopathy typically has a sort of warm-up effect, which you wouldn't see in people with patellofemoral pain. So definitely looking to rule that out. Tibiofemoral pathology can present as anterior knee pain, but typically with tibiofemoral pathology, we'd expect to see some form of range of movement loss, particularly into flexion, which we don't expect to see with patellofemoral pain. Whilst loaded flexion would be provocative, we don't expect to see a true loss of range of movement in either a loaded or unloaded position, unless we start to think about patellofemoral osteoarthritis, which is slightly different again. Isolated fat pad pain, very much an anterior presentation, but typically extension focused as opposed to flexion focused. So I guess they're the big three differential diagnoses that we look to exclude in order to arrive at that exclusion diagnosis of patellofemoral pain. And I guess you can argue if we've got better diagnostic processes for those things than we do for patellofemoral pain. So I guess the simple answer is it's a relatively challenging diagnosis to arrive at, and one that relies on clinical skills as opposed to one diagnostic test or any imaging, as an example.
And can older adults be diagnosed with patellofemoral pain, or is that kind of anterior knee pain description in a certain age category just kind of evolve into symptomatic knee osteoarthritis? How does that become sparsed out?
Again, imperfectly, I would say. So age is a big factor. We have this sort of dichotomous line in the sand of if you're the north side of 45, then you have patellofemoral arthritis. If you're below that, you still meet the criteria for having patellofemoral pain. I see it as being very similar to when we would reach a diagnosis of tibiofemoral osteoarthritis. I'm less interested in what your imaging looks like and more interested in the behavior of your symptoms. So if we see a non-specific effusion, if we see stiffness first thing in the morning, if we see clear post-static dyskinesia, so stiffness after a period of sedentary time, all of those things lead me towards thinking more patellofemoral osteoarthritis as opposed to patellofemoral pain. And it does typically happen more to older people unless there's been a known trauma to the patellofemoral joint, which has led to focal osteochondral loss.
With the guide, the updated guide or this best practice guide, what did you all find as these big priorities of management strategies or recommendations from that systematic review? And then did that align with some of the qualitative aspects, interviewing clinicians and patients in regards to, does the research align with individuals' values and clinicians' kind of assumptions for care as well.
So that's very much the approach we took. So if we start with the systematic review, we set a very high threshold for trials being eligible. So we were only interested in high quality trials on using something known as the Pedro scale, which is a relatively common scale for determining an objective method quality for randomized controlled trials. So if trials scored below or equal to 7, then we excluded them. Anything above, and it's a scale out of 10, then they were included. So we set a very high threshold for trial design, and then we only included outcomes where trials had a sample of at least 23 participants per arm. And that could be achieved either by taking data from a single trial or by pooling data from multiple trials together in order to get above that 23 per arm number. That meant we put lots of trials in the bin. We had 170 trials eligible and 65 met the eventual criteria. So kind of nice bit of side evidence that, we don't have a lack of research. We have too much, and most of it's not particularly good. So we need to be judicious with what we allow to influence our practice. From that systematic review, we had our list of interventions that were effective. If you read the review, you'll read the word efficacious. There's a slight difference between efficacy and effectiveness. In simple terms, efficacy and efficacious are quite difficult to say, so we'll stick with effective for the purposes of the ongoing discussion. And then from that, we had that list of effective interventions, and we looked to marry up what both clinicians and patients thought about those interventions. One of the key things is we didn't allow the findings of the review to influence our semi-structured interviews. That's why if you really dive into the methods of the guide, you'll read that we used a method known as a convergent segregated synthesis. What that means in simple terms is all of these data were collected at the same time and none of them influenced one another, because our worry was if we put a list of interventions in front of people, they will obviously talk about them. Whereas if you allow clinicians and patients to organically bring up what interventions they use, what interventions they've received, whether they think they're positive, negative, or otherwise, you're getting that organic experience, as opposed to forcing people to talk about stuff they wouldn't otherwise perhaps have discussed. So from there, if an intervention was supported by the meta-analysis and was advocated by patients and clinicians, in it went. If something wasn't advocated by the meta-analysis, it needed to be advocated by both clinicians and patients in order to get into the guide. So a couple of interventions made it into the guide purely based on patient and clinician advocacy, but most stuff came in because it was underpinned by the systematic review, and then we added the clinicians' thoughts and patients' thoughts. So there was a reasonable amount of agreement, I would say. There's a couple of interventions where things weren't well discussed. So manual therapy would be the big one. There's some systematic review level data that tells us manual therapy is effective, wasn't discussed by clinicians or by patients. And then movement retraining, running retraining and taping aren't well supported at all by the literature, but very much advocated by clinicians and patients. So that's how those interventions made it in there. But everything else, the literature and the qualitative work aligned well.
Yeah, let's discuss what was aligned well. We can start maybe initially with exercise, if you'd like. What is the recommendation, or what did you guys find from types of exercise, the dosing, why it may actually be beneficial?
So, I mean, the headline is that we should definitely be using exercise with people with this condition. The effects from the review are significant, so we can be very confident that exercise, be it knee targeted or hip and knee targeted, we can be confident that those approaches are better than doing nothing. And then there's very good advocacy from patients and also support from clinicians. The slight difference with our best practice guide compared to, say, some of the consensus documents is our guide very much talks to knee targeted exercise, with hip and knee being secondary. So we've kind of maybe gone full circle a little bit there with that evidence. If you think back to the early 2000s, everything was about knee and VMO, and then we kind of started to think about loading the hip, and now we're kind of maybe back to the start, but can be confident that both of these types of exercise are effective and supported and advocated. There's some nuance, we think, around when we might choose to apply one versus the other. And that comes out a little bit, I think, in you have to make a decision as a research team when something is knee targeted versus when something is either hip or hip and knee targeted. So knee extension, as an example, nice and straightforward. The only joint that's moving is the knee, so we can be pretty confident that it isn't doing much for anything other than your quads. Whereas if we look at leg press as an example, the knee's the prime mover, the quad is the primary target, but there is movement occurring at the hip, right? So your gluteal muscles are going to be doing some things, as is the majority of your posterior chain. So we thought a lot about the exercises involved in each of these trials, and we essentially had to make a dichotomous decision of, is this predominantly knee targeted exercise or is this hip and knee targeted exercise? So I think that's where some of the nuance comes from. Ultimately, loading the knee into flexion, however much the hip is doing, is a good thing.
Do you all, or do we know why it's a good thing?
I don't think we know why. So next steps for this work is trying to really target an understanding of mechanism. So one of the things I often say when I teach research methods is we do trials backwards in our field, right? If you look at a drug trial, the first thing you need to understand when you're developing a drug is what its mechanistic action is. You need to know at a cellular level what that drug is going to do when you expose it to a human system or a biological system. Once you understand the mechanism, you test it on animals. Let's not worry about the ethics of that for the moment. And if nothing untoward happens, then you move into first in man, first in human, and away you go. Whereas we don't tend to do that because the risks and harms associated with physiotherapy or athletic training, whatever term we choose to use, generally are relatively low, right? So we initially start by looking at whether something has a clinical effect. And if it does, we tend to roll with it. So that's partly why the understanding, I think, of mechanisms in our field isn't particularly good. And it often comes afterwards. So I don't think we know yet. There's been some secondary mediation work done. So as an example, one of the trials in the systematic review, and as a result underpinning the guide, is the Fox trial, which was led by a researcher called Mark Matthews, who at the time was doing a PhD out in Australia at UQ with Bill Vincenzino, and Mark's now at the University of Belfast. A friend and colleague of mine, Sinead Holden, was involved. She's big in the sort of mediation field, so she did a secondary analysis of those data and looked for, as example, does hip strength mediate the response to hip-based exercise? And the answer, at least based on that secondary analysis, is no. So whether people get better or not isn't underpinned by how much we change the function of their hip muscles. So more work like that and more trials that are designed to try and understand why interventions have their effects will be useful. I've got one of my full-time PhD students at the moment has just finished a big meta-regression using the systematic review included in the guide here. So I won't say anything about it because it's not been peer-reviewed yet, but it's under review at the moment. That sheds some light on, at a meta level, why some interventions may be effective. But I think that the best answer at the moment for clinicians is we don't know.
Because there's that unknown when explaining that this is a recommended intervention, either isolated knee exercise or combined knee and hip or hip. How do we explain this to patients? Do you have any recommendations on, not providing false narratives or things that just aren't known, but describing the value without diving into some of the specifics that just aren't there yet?
Yeah, I think I'm always honest as a clinician, and I hold my hands up and say that I don't see that many patients on a day-to-day basis anymore. I think it's okay to tell patients that we don't fully know why this is going to help you, but we can be confident that it's got a good chance of helping you. I think that's the primary message. I would steer the conversation more towards why we may choose different types. So what came out of our interviews and focus groups with clinicians is that one of the barriers to knee targeted exercise is symptom severity and irritability. If someone is really intolerant to loading through their knee and you can't find a way around it, then it's probably best to start proximally. So that's where focusing at the hip becomes more prudent. And I think we can explain that to patients through our understanding of why we think people have hip muscle weakness. And we think it's linked to the duration of your symptoms. So you've got this knee pain. As a result of that knee pain, you're not as active as you used to be or you would like to be. And because you're doing less, we're seeing muscle weakness up and down the chain effectively. So it's not the reason you're in pain, but it's still something we want to target. And as we target it, we'll be gently exposing your knee to some load. And then as your pain improves, we can do more. And then before too long, we'll be thinking about pushing you back towards what you want to do, be that climbing the stairs, be that going for a run, whatever it may be.
Yeah, so it's just tailoring the exercise or the tissues being targeted or biased based off of symptom kind of intensity at that point in time. So if the knees are extremely cranky and like knee extensor isolated activities are just too much, biasing the hips or even maybe the lower legs or other muscles of the lower body is valuable and can buy other fitness adaptations and then you can start kind of leaning into some of those more isolated or integrated knee loaded activities as tolerance allows.
Yeah, definitely. And I sometimes say to patients, we're almost tricking your knee into doing stuff. Let's say I get you to do some variation of a monster walk or a standing fire hydrant or something along those lines. Your hip's doing most of the work, but your knee's doing a little bit. And if your knee can do a little bit and your pain stays under control, over time, your knee will be able to do more than a little bit with your pain staying under control. And before you know it, you'll be doing some form of leg press or split squat or something along those lines, So it's, and I think different patients respond better or worse to some of these different explanations, don't they? And over time, you figure out which ones sort of land best with particular patients.
Besides exercise, what else did the systematic review and the qualitative aspects find in regards to recommendations to perform?
So orthoses or foot orthoses, orthotics, technically they should be called orthoses, but again, let's not worry too much about language semantics. The evidence underpinning orthoses is really positive, and one of the things I often say when we teach some of our postgrad courses and stuff is, particularly for physios, if you take nothing away from this other than perhaps refer to a podiatrist more or perhaps boost your confidence with prescribing off-the-shelf orthoses, then you'll be doing well. It's very similar to exercise. The evidence underpinning orthoses is good. Patients advocate them. Clinicians recommend them. The three streams line up really well. So again, they're definitely something we should be looking to employ on a frequent basis. Sadly, we're in a similar position, I think, with exercise in that what's the mechanism of effect? Again, I don't think we know. I try not to come on these sorts of podcasts and say I don't know, because ultimately people want to know, right? But I think we can help people by saying what it isn't. So it's more than you have a flat foot, we introduce an orthoses and things get better, right? You can respond well to orthoses regardless of your foot structure, in the same way that you can respond well to resistance exercise if you're not weak. It's more than a linear mechanism. Fairly similar to what we saw with exercise, particularly from the clinician focus groups. If people are severe and irritable, then orthoses might be a day-to-day intervention that can be beneficial. I think that's another big clue. Someone that's symptomatic day-to-day, I think, is more likely to respond to orthoses because they're an intervention they can use day-to-day as opposed to exercise, which is done at particular points. There was still good support from experts based around what we would call a treatment direction test. So you introduce prefabricated orthoses, or you use, as an example, Lodi taping and repeat some form of functional test, be it a step up, step down, squat, whatever it may be. Does that feel more comfortable? Do you feel more stable? Is your knee hurting less? If so, let's use these things for a short period of time and see how your symptoms behave. So the keys for when we may or may not choose them, I think, are there. How they're actually working, I think we're in a similar spot to exercise.
Yeah, there's unknown, but as you mentioned, providing some caveats as what is not happening, or some of the potential like common narratives as to just like fixing the position of the foot, or with exercise realigning or strengthening things, where it's just that's not a helpful or recommended narrative either, but just also providing the confidence or the comfort knowing that this can be beneficial despite some of the uncertainties of the mechanisms. Is there
we know sorry to interrupt, we may not know what it is, but we're fairly sure we know what it isn't, and we don't want to give people false information.
Is there a recommendation on when someone has patellofemoral pain and you maybe introduce these orthoses, how long should they have it in for until symptoms calm back down and they can remove them throughout the rest of their life? Or what should the recommendations be in those cases?
So if we look at the trials involved, they're all short to medium term use. So we're sort of thinking 12 to 24 weeks is what the trials say. And then where you go from there, I think, is quite patient specific. There are lots of false narratives around orthoses. Clinicians typically don't like them because or physios at least don't like them because they worry that they're passive. Well, my reframing of that is, well, they're not, they're active. People will use them and then they can do more. So they're a passive approach to an active intervention overall. So let's look at it like that. Clinicians seem to worry that people will become addicted to them, or that they will lead to weakness of the intrinsic foot muscles. And in the slightly privileged position I hold now as an academic, I can say, well, let's have some evidence for that, and then perhaps I'll get on board. But at the moment, there isn't any evidence that these detrimental effects occur with long-term use. So how I would approach it clinically is, if you want to start weaning them off, let's go for it and do it gradually. And if your symptoms stay under control, perfect. If you wean them off and your symptoms come back, well, then we've got our answer about whether you need to keep using them or whether you can wean them off. The whole patients become addicted to them thing, I look at that very much as the narrative that you give as the clinician. If you as the clinician say you must wear these every day for the rest of your life and you must come and buy a new pair from my practice every 6 months, I can see how patients would become addicted to them. But if we present them as, I'll steal one of my podiatry colleagues' favorite terms, they are just another arrow in the quiver of management. Some patients will use them for a very short period. Some people will use them for longer. It's some of the people, some of the time.
And does it matter if they're these kind of cheap over-the-counter orthoses versus tailored and fit and made for that individual that are pricier? Is there evidence to suggest one or the other?
I think it's somewhere in the middle, in that there are very few trials on truly custom orthoses because that comes at a cost, and money is a barrier to most good things in research. So if you really get into the methods of the trials, they're prefabricated devices, so they're very much off the shelf, but then they're customized for comfort. So what actually happened in the trials is people were allowed initially to trial a variety of device stiffnesses. So people could try a super soft and flexible device, something in the middle, super stiff and firm device. Which one feels most comfortable? The patient chooses. Okay, that's the stiffness we're going with. Now, what about the length? Do you prefer a full length device? Do you like a 3/4 length device? Do you prefer a slim fit device because you wear particular types of shoes day to day? Once the patient has chosen the stiffness and the length of the device, okay, what about a heel raise? Is it more or less comfortable with a heel raise? Heel raise on or off? Is it more or less comfortable with a first ray cutout? Et cetera, et cetera. So there's a lot of thought process now around comfort in terms of no different to anything you put under your feet. If they're not comfortable, you're probably not going to wear them for that long, right? So you've got to think about giving someone a device that's comfortable. And then from there, if good things are going to happen, they've got a better chance of happening. So there's nothing wrong with a prefabricated device. And that's where I'd encourage people to start. And then if people get on really well with a prefabricated device, the only real motivation for going for a custom device is longevity, right? A custom carbon fiber device is going to last an awful lot. Well, essentially would last for the rest of your life. It will just need its top cover replaced from time to time. Prefabricated devices, depending on the size of the patient, their body mass, etc., you're going to get 6 months to a year out of them before they need to be replaced. So do you want to spend a little bit of money multiple times, or do you want to spend a bit more money once? That's kind of the way I would look at that decision.
Yeah, so these first two recommendations or interventions, exercise and orthoses, there's still a lot of variability and flexibility depending on the individual and their tolerance and their comfort levels. And that's freeing probably to a patient and to a provider to just have wiggle room and exploration of, okay, let's potentially try some orthoses. And these are the range of things you can experiment with, all of what you said, and find the one that's the most comfortable. And then discussing, like, if you just want one that lasts a lot longer, but it's a higher price, that's up to you to determine whether that's worth it. And then with exercise, again, it's like, let's explore all these potential movements and options and the things you value and what you're doing, and how do we adjust accordingly. So it's great that there are recommendations, but within that, there's a lot of flexibility.
Absolutely. And ultimately, that's what patients want. So there was a real theme within the qualitative interviews that we did with patients with patellofemoral pain around individualized care. Now, some of this might be influenced in some way by our sample. Most of them were UK based, and as a result, most of them were treated within our National Health Service. But I can remember a quote from one participant that really sticks in my mind, which was, I've been referred to an exercise class and I've got pain at the front of my knee, and I'm in a class with people that have got back pain and shoulder pain and foot pain, and we're all doing the same stuff. So how on earth is that going to get me and my knee pain better? Now, I'm open to the notion that it may do, right? That the effects of exercise are wide-reaching and may be in some way non-specific and contextual, et cetera, et cetera. And I'm open to the fact that an exercise program given to people with pain in two different joints may lead to success, depending on the person. But what's key, I think, again, is the narrative. It's how we communicate this stuff to patients. So they want individualized care, and that links into the underpinning education. So one thing we haven't mentioned thus far is, regardless of the intervention we're choosing, both patients and clinicians were very clear that everything we do needs to be underpinned by education, right? So patients want to know how this is likely to help, why we're asking them to do it. And clinicians very much agree that if we do this stuff well, we wrap it up intrinsically with good information that we provide to patients that we then make sure they understand, and that gives us the best chance of success. So if we think about that particular patient who was upset about being in a group class, that his thought I think it was a male patient anyway, his thought process may have ended up being very, very different had he have been given different information. So that's key.
Yeah, to that point, staying on education, besides these management options or things that are recommended, what should we be discussing on potential timelines and prognosis of how long to expect potentially with patellofemoral pain symptoms? And also going back to exercise, what is safe or recommended in regards to what people can or should be doing from a symptom perspective? If they're asking, should I avoid all exercises that have any type of knee symptoms? Or is it tolerance based? Let's go into just timelines and prognosis, and then kind of pain monitoring and what we should be discussing there.
So from an education perspective, one of the drums I always look to bang is around diagnosis. And from our qualitative work, it's really clear that patients want a diagnosis. They want to leave that initial consultation with a diagnostic label that they can take back and explain to people, which is interesting because the clinician interviews we conducted were completely the opposite. Clinicians don't think diagnosis is important. This is a non-specific condition, and whatever we call it isn't going to change the outcome for patients. Well, patients don't agree. So I encourage now people to give a diagnosis. And I liken that to the very few times where I go and knock on the door of my GP. Most of the time I want to know, have I got some form of bacterial infection that requires antibiotics, right? That's the information I want. And I want to go away with the information of, yes, you need antibiotics. Here's your prescription, go to the pharmacist. Or, no, you don't. You'll be better in a week. Go away. So I think this is very similar. People want to go away knowing what they have and knowing what they should then do about it. So I think that's super important. And that then links into prognosis. So ultimately, the current prognosis for people with patellofemoral pain is poor. The headline statistic that we put at pretty much the start of every grant that we write is over 50% of people are still symptomatic 5 to 8 years diagnosis. So post-diagnosis. So it's very much not the self-limiting, go away, come back in 3 months if you know better advice that unfortunately often comes from general practitioners, at least here in the UK. So one of the messages we're trying to get out there is this isn't a self-limiting condition. And when you see people with it, please refer them at that point. Don't prescribe some nondescript anti-inflammatories and tell them to come back in 3 months if they're not better, because chances are they won't be better. So that's an important part of the education piece. I think if we set people up for the fact that this is going to be better in 12 weeks, we're doing them a disservice. I used to have a line that I'd pull out for patients with tendinopathy, which is that this gets better over months and not weeks, and sometimes years and not months. The more work I do in this field, the more I think it works for people with patellofemoral pain. That's not to say that you won't be doing well within months, but for us to achieve complete resolution of your symptoms, it's going to take time. So we need to make sure that we don't set people up for failure in that regard. And that then, I hope, links into the final part of your question around exercise, which is that all of the exercise trials that have been done well and have an appropriate sample are all short-term, right? They're all up to and including 12 weeks. So we need to be very diligent with our approach to exercise within that time window. And then whilst the evidence can't support it at the moment because we really lack long-term trials, chances are we then need to continue, right? Whether we need to be as diligent and whether we can reduce the frequency, that's a little bit like the orthoses question for me. If people start to reduce the frequency of completing their rehab and their symptoms continue to behave, fantastic. If they don't, then perhaps you need to continue to stimulate the system more frequently in order to keep your symptoms under control.
Yeah, it's really helpful to know that it's not a self-limiting condition compared to other diagnoses where it either is kind of a quick or favorable natural history, or it's a little bit longer, but it will probably resolve. And so knowing that this can still be occurring 5-8 years down the road sets appropriate expectations for both the clinician and the patient. And if you're discharging them, let's say in a few weeks or a few months, just setting up the appropriate kind of confidence and competence with what do they do moving forward, knowing that they probably will still have symptoms and that these symptoms may fluctuate over multiple months or years. And what are these underlying things to focus on or principles to feel reassured that I still have symptoms and maybe some limitations, but I have kind of autonomy and control of what I can continue to do or how I can dampen down some of these symptoms during this kind of prolonged period of time.
Absolutely. Along with whatever positive messaging people require, right? So that came out strongly in the focus groups we did with clinicians. If people are concerned that this is going to predispose them to osteoarthritis, well, we can dispel that. If people are concerned that the noise in their knee is bone rubbing on bone, we can dispel that. If people come in with a label of chondromalacia patelli and that frightens them, we can explain that that's a radiographic term and there's more articular cartilage on the back of your kneecap than anywhere else on your body. So consistent change across the entirety of the patella is just age and activity related change, wrinkles on the inside, no different to your hair going grey, or all this kind of stuff that sticks with certain patients and not others. If people link pain to tissue damage, we can help dispel that myth. We can talk about tissues being sensitized or irritated rather than damaged. So just because this is a persistent condition that can have a poor prognosis, not necessarily something that automatically has to be frightening. And some patients do very well self-managing once they put that fear to bed and know that they can keep doing what they want to do, and with some tips that helps them to control their symptoms themselves.
Brad, is there anything within the best practice guide, recommendation-wise, besides exercise and orthoses and that underpinning education, anything else that was strongly recommended before we dive into the things that are potentially not appropriate or not recommended?
So the interventions that we haven't discussed so far are manual therapy, run retraining, and taping. I'm going to do them in reverse order. So taping is tape. Well, let's look at both taping and movement retraining, running retraining, whatever we want to call it. Both of those interventions are in the best practice guide because they were advocated by patients and recommended by clinicians. There aren't any good quality trials with enough people in them for us to be confident about the effect from those interventions. Particularly taping. There aren't many trials of run retraining at all, and lots of the taping trials are quite small and poorly conducted. But despite that, patients like receiving those interventions, think they help them, and clinicians would agree. So taping, my typical analogy is it's like paracetamol for a headache, right? If you have a headache and it's severe enough to limit you from going about your day-to-day business or something specific, you may choose to self-medicate. Taping is very similar. I think if someone has particularly severe and irritable symptoms, and that's the biggest feature of their presentation, right? They're not saying, I can't do as much running as I would like, or I can only lift X amount in the gym. If they're saying this is bothering me day to day, it's hurting most of the time, that's where taping comes in. And that's effectively what came out of the clinician focus groups. Similar message around no certainty around the mechanism. What I would say to patients is this is a way of changing the input to your system, and sometimes changing input leads to positive changes in output. So we're going to try this, and if it changes your pain, generally it comes about relatively quickly. If it helps you, it's something we've got for a short period of time to help get that pain under control. This isn't going to fix your symptoms. It isn't a long-term solution. It's a simple bridge to what we need to do next. Running retraining, again, this sometimes sounds a bit too simplistic, but this is for people that have running specific symptoms, I would say. So if we're not seeing day-to-day symptoms, if we're seeing people that have symptoms that are solely related to running, then it makes sense to look and see if there is a target within their gait that may be amenable to run retraining. And the big one that came out of the focus groups was if someone has a particularly long stride and typically associated with a particularly low step count, it may help them if we look temporarily, perhaps to increase their step rate via a metronome or some other form of external feedback. But similar principle, any form of run retraining hasn't been underpinned by a good quality trial yet. So that's those two.
Let's go into what you all defined as not appropriate interventions. Can you, I don't know if I've ever read a study where it said not appropriate. Is there a recommendation or a reason why it was not appropriate versus not recommended? And I think you added it's not appropriate for use outside of a clinical study or a clinical research group. What are those first, kind of why it's not, why it's that verbiage, and then what actually were the things that were not considered appropriate?
So we decided on that term because all of these interventions, so anything that was not recommended, came out initially from the systematic review, right? So these are interventions that the systematic review outcome said either this is no better than doing nothing, or adding this to something else is no better than just doing the intervention on its own. The reason we opted for not recommended outside of a clinical trial is the certainty of the evidence from the systematic review ultimately is quite low. So everything is very low apart from dry needling combined with hip and knee targeted exercise, which was moderate certainty. And then outside of a hyaluronic acid injection combined with hip and knee targeted exercise therapy, that was the only intervention where there was actual agreement from patients. So that was the one intervention where patients said, yeah, actually, I was offered that and I had it and it didn't help. Across the board, everything else wasn't discussed. So we wanted to be appropriate in our language, in the sense that all of these outcomes come from not many trials, and there wasn't clear directionality from clinicians and patients. If we had higher certainty using grade within the systematic review and clear recommendations against from the qualitative work, then I think we would have been stronger. So that's where we got to. So we, in essence, we were trying to reflect the fact that maybe we don't fully know the answer yet. So if someone wanted to run another trial using these interventions, we would support that. But clinically, we think you're pretty hard pressed to be able to justify doing any of this stuff ultimately. And they all make sense to me as I look at them. You know, it's quite clear that dry needling compared to sham needling wasn't superior. So any effect is likely to be contextual. As a result, when we add dry needling to what we know is effective, being hip and knee targeted exercise, and we're not seeing any additional benefit, why would we bother adding needling to something that is effective in its own right? Same very much true for vibration therapy. I mean, I wouldn't say there's any biological plausibility as to why exercising on a vibration plate would be better than exercising off of it. So that one didn't surprise me. The combined interventions and foot orthoses, I describe that as perhaps there is a limit to how many things we can throw at the wall before stuff stops sticking. We've got these combined interventions that were tested in a trial by Kay Crossley back in the early 2000s, which was hip and knee targeted exercise, some taping, some muscle stim, and some local soft tissue therapy around the knee. That's already quite a lot of stuff to do. So when we do that and give orthoses, there's no additional benefit. So those things probably need to be separated. I guess the one that surprised me is the hyaluronic acid injection. So at least here in the UK, hyaluronic acid would be marketed as a joint lubricant. It's not technically a drug. You can buy it on Amazon. You don't have to be able to legally prescribe to give it to patients. You need to legally be able to inject, but you don't need to legally be able to prescribe. And prior to doing these works, it's something I would have referred for, right? I'm not a fan of corticosteroid into the patellofemoral joint, because corticosteroid aligns with a synovitic or inflammatory joint, and there's plausibility around a mechanism of why it may help someone with an inflammatory joint. Patellofemoral pain's not an inflammatory condition, so if we're putting an anti-inflammatory drug into a joint where there isn't inflammatory tissue, we're going to see the chondrotoxicity of corticosteroid act on the patellofemoral joint, which is not a good thing. But we've got a patient with stubborn symptoms who we can't get over that initial hump. If they're interested in a more invasive intervention, hyaluronic acid makes sense, because if it's injected by someone who is highly skilled and judicious, then the potential for the negative effects almost non-existent, and the theoretical mechanism of this will bathe your articular cartilage and improve the lubrication in your joint, patients buy into that. I've also seen patients who have got really stubborn symptoms. I can't get them where I want them to be. They go off and have a HA injection and they do better. But it would appear that if they are doing better clinically, it's probably contextual rather than biological, because in this one particular trial, a HA injection combined with exercise was actually inferior to a sham injection, so saline and the exercise intervention. So you can look at that in one or two ways. Either the effect is coming from the exercise or the effect is coming from the contextual. I've seen a physician, they've stuck a needle in my knee and now I can do more.
You've mentioned sham a few times with sham needling, sham injection with the HA. With exercise, how do we know that exercise is beneficial in regards to, we can't really compare it to a sham, or how have studies been able to sparse that out besides just like doing nothing and then exercise? With that intervention, it's really hard to sham it. So do you have just general thoughts there, or has research tried to differentiate that?
Yeah, I do have thoughts. And I think it's really important that we don't mix up sham and placebo, because they're different things, right? And placebo ultimately is easy to do in a drug trial, because you can have a sugar pill which is biophysiologically inert, but it looks and smells and tastes like the actual drug we're testing. That works. Whereas in our field, I would argue most of the time placebo is impossible. Now, technically, you can deliver a placebo if you can convince a patient that they are receiving the intervention that the people in the other treatment arm are receiving. But I think that's really challenging. So most of the time, if we use that type of control in our field, it's very much a sham. We're trying to do a pretend version, but it's not inert, because if you do sham needling, the needle tube touches the skin. If you do a sham injection, you still penetrate the capsule of the knee, and normally you still inject a substance. In this case, saline. Is saline inert? Definitely not, right? So, but if we look at exercise, that was one of the method decisions we made, in that we only wanted trials that compared things to doing nothing. And there aren't that many, because ethically, it can be very difficult to get permission to do nothing, because we have an understanding that most things have some form of an effect. So convincing an ethics committee that I can compare this to nothing, because we aren't certain that nothing isn't the best thing to do, can be quite challenging. And we built from there, right? So the only compared to nothing exercise trials we have use knee targeted exercise. Because knee targeted exercise is better than nothing, we could then compare knee targeted to hip and knee targeted. And if hip and knee targeted is the same, then technically that's also better than doing nothing, because we're comparing it to something that's better than doing nothing. Hopefully you're still with me. Same for orthoses. We've got some orthoses trials compared to wait and see. We have the manual therapy trials compared to wait and see. And then we've got the knee targeted exercise with perineural dextrose. Well, that's in there because we know knee targeted exercise is better than doing nothing. And that's how we could make the comparison. So all of the not recommended interventions, it either had to be compared to doing nothing, or it had to be compared to something that we know does something. Does that make sense?
Yeah, it does. I think earlier on you had kind of clumped the running, retraining, the taping, and the manual therapy. I don't know if you actually ended up touching on the manual therapy. Is there anything you wanted to discuss there, or kind of similar sentiment of the narrative around taping, where it can be kind of the short-term symptom or sensory modifier? It's not a long-term solution, but it can allow access to exercise and more active forms of intervention. Anything else you want to add there?
I thought I'd got away with it. There are, in essence, two answers to this question, right? So if we look at the trials included, they're what I would call pragmatic trials. So it wasn't everyone received the same manual therapy. It was patients were assessed, and then dependent on the clinician decided level of hypomobility, they then received mobilization or manipulation anywhere from the lumbar spine down, in essence. So a relatively osteopathic, chiropractic approach, certainly not something that we would necessarily see that frequently in physiotherapy here in the UK. So I think you can look at that one of two ways. You can either look at that as judicious use of manual therapy, and if you think that patients have particular joint hypomobility in an area, and if patients have a preference for manual therapy, etc., there's your justification for doing it. My always skeptical academic answer to the question is, if I look at the effect sizes in those trials, they're very big and the confidence intervals are very small. And whenever I see big effects and small confidence intervals, I'm always suspicious about the validity of those data. We couldn't exclude them because the trials met the quality criteria, they're published, they are available. I can't allow my bias to influence the outcomes of the research. But gun to my head, I think if those trials are repeated, you will start to see that effect size washed out, possibly to the point where it no longer meets the threshold of clinical utility. I guess another thing to say is I think we found it interesting that there wasn't an effect for pain, but there was an effect for function. One of the often reported mechanisms, at least here in the UK, for manual therapy is that it's a window into treatment. It's a way of changing pain. In this, it's the other way around. The effect came from function scales. So maybe patients benefit from some form of hands-on care. Maybe that reinforces a caring narrative, therapeutic alliance. Ultimately, it could be explained by a number of factors, no different to any of these interventions. So I think that's one people have to decide what they feel about it. And 5 years into this now finished project, I'm still not entirely sure I know exactly how I feel about it. So I'm not being that helpful, I appreciate. But
yeah, thanks for adding and elaborating on that. Is there anything else, Brad, within this guide or within patellofemoral pain that we haven't touched on that you want to before we close it out?
Other than that, I really hope people delve into the methods of the paper and seek to understand the judicious approach we took to aligning quantitative systematic review data with the thoughts and feelings of people with the condition and people without the condition. Ultimately, mixed methods are quite messy, and you have to find a way to do it without allowing your own biases to influence the outcomes. And I think we've done a good job of that. I think it's fairly obvious who put it together if you know us as an author group. But I think at the moment we have to take it for what it is, and I don't see this changing a massive amount until we start to get some bigger and better trials in the field. So one of my pleas to funders out there and people that do this work, whilst studies are stepping stones often to other pieces of work, another trial with 10 people in each arm is going to change nothing. So if we're going to do more trials, we need to look at doing big trials, and we need to follow people for a longer period of time so that we can start to understand the longer term effects of what at the moment is a relatively short term piece of work.
Yeah, understood. Well, thank you for chipping away and doing this and putting in the hours and years that it takes to create these type of guides. So looking forward to those other ones you were talking about, like tennis or lateral elbow pain and the others that will come out. I'm assuming those will take years as well.
Well, hopefully they won't take as long, because getting £500,000 allows you to employ people to do stuff. So we've got my colleague, Professor Dylan Morrissey, who's the academic lead at Queen Mary, led on that grant. So we've got 2 very capable postdocs employed there now who are ultimately going to do 3 of these things each. They're going to aim to get one done per year, basically. So it's on paper it's a 3-year project. The idea is that they produce a guide every year. The 2 we mentioned are underway. So lateral elbow and rotator cuff. There will be recruitment materials going out. So no different to what we did here. We're looking particularly for the clinician interviews to be multidisciplinary. So we want to talk to physios, but we also want to talk to surgeons and physicians and athletic trainers and people from all walks that may encounter these patients. So if you're interested in influencing these upcoming guides, then do look out on social media and put your hat in the ring to be interviewed, because that's what we need ultimately for these to work.
Perfect. Well, we'll link your contact and information below and the paper as well if people should and probably will dive into this guide. We'll call it there. Thanks, Brad.
No worries. Thanks for having me.